off your cap. That got screwed on a little bit. Now, again, there's going to be a couple different ways. We're going to show you the sterile way. All right, so that tip has not been touched. So she can touch it. Now everything else she's not going to be able to touch. So now I'm going to rotate the head down. She's going to disconnect from the manifold, hopefully. Is it too tight? Put it on too tight?
Yeah.
Get your hemostat. I've done that myself. You'll do that yourself. You gotta hold that little piece, the rotating part. There you go.
I had another hemostat.
Stat somewhere. So make sure you're not tightening that on too tight or it's going to be difficult to get off. Right, pass that off a sterile manner. And you can, this is a good thing to always see so you know, well, how would I fix something if I've done this? Now, I'm going to go forward so you can see that there's a little bit of flesh coming out. All right, and then blood is going to be backing up, actually. So go ahead, connect it. Could be that you need to unscrew it a little bit more. Yep, more. So it fits in there just so, okay?
There you go. That way. It does not look like.
You gotta just keep it in there. All right, and then, so once you've slid it in that little nozzle part, you're going to screw it back on, make sure it's nice and tight, okay? Just hold this catheter down in there for me. All right, next thing we need to do, there could still be some air, even though we did a fluid-to-fluid connection, just like when we're connecting our catheter. So you want to draw back. You're going to use your little knob, and we're actually getting air because that popped out, and there's always going to be, but we wouldn't be getting that much air whenever we're in the body. You could have a couple little bubbles that would be coming, but we still want to clear. At this point, we would be having blood also coming back, okay? We're going to tap it here. She could take the hemostat or a syringe and tap it here. Okay, being careful again not to touch anything that's not sterile. All right, we look good. We have cleared the air, okay? De-aired it, so to speak. Now, some doctors might have us to go forward a little bit just so that we fill the line with contrast and it's not all filled with blood and then contrast has to follow. Because it's going to count that blood as our injection volume. And if we want a full nice picture, then we want to fill that tubing with contrast. All right, looks like we have 56 in here, but if you'll notice, I did get kind of a large air bubble right there. I've never had that happen in the real world because we're inside of the patient. And so you may have a tiny, tiny air bubble. As long as it's up here by the hub, then you're gonna be fine, okay? And we do wanna go as vertical as possible with our injector head to do that injection. All right, now we're going to set, and I'm gonna do, we'll do 15 for 2. That'll give us actually 30, which will give us a volume of 30. I'm gonna just do a pressure of 200 so you don't get spurted, hopefully. And no rise time, okay? We remember, y'all know how to program these. Whatever the doctor wants. Then I'm gonna arm it single. All right, again, it tells me do not inject air. Have you expelled all air from the syringe disposable? Yes. Now I'm ready to do my injection, all right? We practice this, so you guys already know how to do the injection. I'm not gonna test you on this part. What I'm testing you on is being able to connect and disconnect and reconnect, okay? But we're just gonna go through the motions, okay? So, doctor steps on Cine, injecting, injection is finished, and hopefully that'll bring back those memories also for you. And now, Kaylee, you can, I'm gonna hold this in, go ahead, and Kaylee's gonna disconnect, keeping it sterile, her hands sterile. So she's gonna take the tubing off. And I would get this up out of the way. And then she's gonna reconnect to the manifold. Now, you wanna, if you can do a fluid to fluid, what you could do is take that back off, Kaylee. You could actually turn on your pressure, your flush, and let them see that, now you have to turn off pressure, turn on flush. So it's coming out on its own. Then you can have a fluid to fluid without you actually having to push with the syringe. Now you need less flush, so you need to put back some of that flush. So once we have connected fluid to fluid, now I have seen, some people maybe not let the flush come out on its own. You're just gonna have a little more air in that area, okay? But then she's just going to aspirate, flush, and turn to pressure. Pretty simple. Now we have our LV waveform again, and then this is when we would do our pullback and get our LV to AO pullback. Now when we talked about TAVR, if we would have been doing a TAVR, we probably, now unless we have had to do some pullback because the dual lumen is on back order, so then we would have to disconnect and then reconnect. We would have just left our power injector here and it would have been filled with more. We usually go ahead and fill it with 150 cc's of contrast. If we did have to disconnect, we would just disconnect, get our pressure so that we could do our pullback, and then disconnect again, reconnect, purge, and get ready to do the ascending and the abdominal injections. If we had that dual lumen and we got our simultaneous and doctor was fine with not getting an actual pullback pressure, then we would just actually leave this all connected. He would pull the catheter back, we would put it over in the LAO position, do the ascending arch shot, put it in the AP position, pull the catheter down, do your abdominal, and then we would do our disconnection. And you actually, in that situation, wouldn't have to do as much as we just had to do to reconnect. I mean, you still have to disconnect your extension tubing and put it back here, but you're not worried about pressure. There still could be some air, so of course, but when you go to reconnect the next catheter, you're going to be flushing and you're going to flush that air out anyway. Does that make sense? Okay, so that's how we're going to do it. Now,